the United States, if you think about the United States, not only is nicotine psychoactive, but there's over 1 billion smokers worldwide, and there's close to 8 million deaths worldwide. Okay, and so we often will think about, wow, that's this is a not only a significant problem, but it goes along with a lot of other problems and a lot of other comorbidity. And in the U.S., you can think of just short of 500,000 year in and year out that die directly as a result of tobacco. So that's a pretty high number when you think about it. And then alcohol is number two when it comes to substances, if you will. And again, both legal substances, as we've talked about. So nicotine, for many people, is somewhat of a stimulant, but it also is a relaxant, if you will, through its mechanism of action. There's intense cravings that go along with it, and then self-administration. Remember the 4 C's when it comes to addiction, right? The 4 C's of addiction are loss of control, that inability to kind of cut down or control your use, compulsive use, despite the consequences. People keep going. So compulsive pattern of use, consequences, and then the fourth is cravings. Cravings start out of conscious awareness. They start deep in the basal ganglia and the ventral striatum, and then they proceed to conscious awareness through various kind of pathways. So cravings are one major mechanism that's a driver of the four things that are related to a addiction or substance use disorder. If you look at the worldwide kind of global smokers, you can see that between 1990 and 2019, it's really shifted to Africa. The kind of more orange or colors means the numbers are going up. Blue means the numbers are going down. We've gone down in the United States and in North America, but Africa, the number of smokers and a few other areas in the world, it's actually gone up. We've gone down in the US, and interestingly enough, back in the 60s and 70s, when the peak was at 42% of the population was smoking at one point in time, and this is before there was a lot of kind of public information, even though it was known before this, public information put out. The number of smokers was really high. And the single most effective ingredient to decreasing smoking was scare tactic, quite frankly. So showing pictures of bad lungs and people on oxygen and that had, COPD and so on. And so we are now down to, in the US, depending on where you're at, somewhere in the neighborhood of, 10 to 15% or about 12%. So the numbers have come down significantly in terms of smoking, which is a terrific deal. So 12.5% is kind of the number I gave here. It's, probably the most common cause of preventable kind of problems in the US. You've heard me say 480 or just short of 500,000, and there's an enormous amount of money spent in this. So this is a summary slide of what I've said. You can see the numbers. Incidentally, you'll have access to the slides if you want to review them at the end or on the website. So what about who's smoking, right? Well, in general, if you break it down this way, the people that have the lowest amount of money, if you will, and the people that have the lowest amount of education have the highest degrees of smoking in the United States. And so I don't need to read you the numbers here. Just remember lower education and lower socioeconomically have higher rates of smoking. When does it start? Well, as we've talked about many times, most substance use disorders and most psychiatric disorders start between the ages of 12 and 25. So during adolescence or extended into emerging adulthood. And the earlier you start, the more likely you're going to develop a substance use disorder, regardless of what the substance is. And the greater likelihood that you will have comorbidity, meaning that if you have mental illness early on, more likely you're going to develop a substance use disorder. So the peak, incidence for starting is somewhere between the ages of 14 and 25. That's the critical intervention window, and that's where you can change the trajectory of what takes place. And so, again, I'm not going to read you the numbers. The idea, most importantly, if you're working with young people and so on, don't overlook the opportunity to ask them about substance use and to ask them specifically about gateway substance use, meaning tobacco products and alcohol, marijuana as well. So here you're looking at data from 2022 in the National Youth Tobacco Survey. And, 16.5% of high school students and 4.5% of middle school students are using tobacco products. So those numbers are pretty high, 11 point, a little over 11% altogether. What are they using? Well, smaller percents of people are using the old-fashioned combustibles, but there is still a progression from e-cigarettes to combustibles. 1 in 4 of those that are using electronic or e-cigarettes, and mostly disposable. And by far the treatment, or the not the treatment, the choice of use is flavored e-cigarettes. So those that have kind of attractive flavors are by far and away the most common that are being used. Menthol is a big one within that group, and especially in African Americans, menthol flavors are significant problems. And remember that tobacco use and nicotine is related to most common causes of death in our country. The most common causes of death in our country really have things that are associated with them, tobacco being one of them. So when I say things associated with them, if you think of tobacco, it's associated with hypertension, stroke, cancer, as you know, coronary artery disease. But don't overlook the importance of other components that are often overlooked in this setting, and that is, to a degree, diet, but often lack of movement. Lack of movement, including whether you want to think of it as anaerobic, aerobic, or resistance kind of training, if you will, is less in smokers in general. And therefore, it's an additive thing because you get insulin resistance and all kinds of other variables that then contribute to coronary disease, stroke, hypertension, and so on. Now we're in a whole additive effect, if you will. So if we could think about strategies to really target cigarettes, it has effects in numerous domains of various other health components, and especially the menthols are very attractive, is the slide there. Now, let's talk about what makes a substance addictive. What gives it the addictive potential? How quick it gets into a system. And the quicker it gets in, meaning inhalation or injection are the quickest, the more addictive it is. And you add to that, not only the quicker it gets in, but how long it lasts. So things that come in and out quick have a tendency to be more addictive. Potency is associated with addiction as well. So if you think of, let's use opiates as a simple substance. If you think of heroin that's very pure, okay, that's not adulterated with other substances, heroin comes in and out quickly, and the more potent it is, the more addictive it is. The minute you start to kind of add other ingredients to it, it reduces the addictive potential. So you have to be careful when you're cutting it on the street, regardless of what you're cutting it with and selling it, that you don't lose addictive potential, or you lose your customers, if you will. And so addictive potential has to do with purity, but how quick it comes in, and then how long it lasts. So heroin is in and out quick. Well, cigarettes are in and out quick. And so they're very addictive. If you compare studies of the most addictive substances, nicotine's at the top when you think about it. Tobacco and cigarettes specifically, because you smoke them, combustibles that come in quick, they go out quick. And so it changes the equation compared to those substances that come in slower and last longer and are less potent, or route of administration is what this slide is depicting here. All right, so let's talk about mechanism a little bit, and mechanism of action preventing dopamine breakdown. Remember that we have mentioned through echo, dopamine gets a lot of attention. It's only one player in the equation. We're talking about a whole range of neuromodulators and neurotransmitters that influence each other, that have effects on kind of how things work. So, for example, if you let's take the antithesis or the opposite of kind of dopamine surge. And let's say we want to block dopamine. One of the treatments for alcohol use disorder is to use a mu antagonist, naltrexone. By it blocking the mu receptor, it prevents the release of dopamine downstream. So it's not a direct effect. So we're talking about different systems modulating each other, if you will. It's not just a dopamine phenomenon, if you will. So I don't want you to be led of, oh, if you just affect dopamine, that's the only thing that's really happening. It doesn't work quite that way. So if you think about mechanism of action, inhalation is a in and out quick. It's a self-titrating thing, meaning different cigarettes have different potencies, if you will. And it has to do with things you already know about: puff volume, depth of inhalation, and the rate of intensity. So how someone's really taken, when they're taking a drag on a cigarette, if you will, how much they're inhaling and how strong they're, in essence, inhaling with that determines how much is going to get into their system. And that does make a difference. Also, absorption, depending on kind of how it comes in, is influenced by variables such as pH and how alkaline a product is. So the more alkaline it is, the more it's going to be absorbed through the buccal mucosa. So if somebody's chewing or is smoking cigars or whatever that are alkaline, there's going to be a greater rate of absorption. Well, this has to do with how addictive something is, right? And so if somebody is, so think of our harm reduction discussions, right? And it may be a progression towards something that's less potent, less alkaline, and so on, less absorbed as a natural process in maybe mitigating or reducing the amount of nicotine that's going to be absorbed. And then where it's distributed, the nicotine is distributed throughout the body, but especially in kind of key organs, including the brain. And it does accumulate in gastric fluids and in breast milk and so on. So it doesn't have a high affinity compared to some substances, for example, marijuana, for adipose or fat tissue. Adipose tissue is over time, marijuana goes there. That's why if somebody's been using marijuana, it can take a month or sometimes a little longer for it to come out of their system because it trickles out of adipose tissue. Not so much with nicotine. And so it gets in the brain quick. Remember that? We're talking about inhalation. There you go, back to the idea of addictive kind of potential. It gets to the stimulating systems through our circuitry that influence kind of addiction. So take you take a cigarette, you're smoking it. Within a short period of time, you get dopamine released in the midbrain, which is the ventral tegmental area. It sends out signals to various aspects, including euphoria areas, which is primarily in the nucleus accumbens. And then from the nucleus accumbens, it goes out into kind of memory circuits that are out of our conscious awareness initially. So it goes out to hippocampus, sends signals out to the insula, and so on. And as this signal's progressing and dopamine is released, then it is associated with a feeling along the way, and we're consciously aware of that, oh, I feel better, I feel more relaxed. I appreciate the stimulation of getting me going in the morning, and so on. So you get a cascade of these releases of neurotransmitters, which I've led us to kind of this next slide. And beyond the, oh, I'm using it to diminish my appetite or lose weight or increase my metabolism, you now are getting glutamate effects and acetylcholine effects, which has to do with cognition, so memory and that arousal and so on. But then norepinephrine and dopamine kind of are synergistic in a way, to activating and euphoria and pleasure, and you get the idea. And so nicotine affects various neurotransmitters, and I've said this already. You can see the list of what it does here on this page. I'm not going to read through them individually, but it has effects on what we've been talking about: arousal and stimulation and relaxation and cognitive abilities and so on. Um, and so just know that there are widespread associated effects when it comes to thinking about nicotine. Now, the numbers are off on this page a little bit in terms of price because prices change, but know that average pack of cigarettes in the U.S. Varies from state to state. It's close to, I think, $12 now in New York. For the average in Nebraska, depending on the brand, is higher than 6.28 now. It's probably closer to $7. But if you smoke one cigarette with 10 puffs and you have 10 doses a pack, 200 doses. So 30 pack years, is a lot of doses, if you will, and a lot of money. This just reflects a strategy to talk to patients about that may be an incentive or motivator to say, look, this is what, if you were to smoke 30 years, you may be spending $100,000 on cigarettes, depending on the brand and so on. So sometimes that gets people's attention. Liver is where most of the action is, along with the brain and the lungs. The half-life of nicotine is about 1 to 2 hours. One of its metabolized cotinine is 16 hours. For those that have been using for a period of time, metabolic machinery in the liver, phase one metabolism increases. There's an induction process that takes place with nicotine. And then when someone stops using, those substances are metabolized by the cytochrome P451A2 system. The blood levels of those medications can actually go up. So things like whether it's Zyprexa or which is olanzapine, or alprazolam, Xanax, or duloxetine, which is Cymbalta, those levels can go up, and sometimes people will have side effects as a result of smoking cessation. Tobacco comes in, and as you all know, a number of products, a number of plants, and there's a number of ways that are accepted. Not only what's mentioned here, some people, especially outside the U.S., although it's picking up in the U.S. to a degree, are using hookah. So there are various ways to ingest tobacco, whether it's or pellets, this has about just short of a milligram of nicotine in them, or more potent like cigars, or some loose leaf kinds of things. You all know this. I'm just reminding you of various tobacco products that are out there and that are being used. Here is the Juul pod. One Juul pod contains about the equivalent of 20 cigarettes worth of nicotine. It comes in a lot of flavors. This is the growing, as everyone knows, and the use of Juul pods are growing. And interestingly enough, it's made by Philip Morris. And as you look here in the quotation from Philip Morris, basically they came out and said, gee, it's really important to know about teenagers and their smoking patterns, because we're going to capture them and take advantage of them. And when they're using, and they really target that group because they know that's the age group where people start, which is Philip Morris manufactures Marlboro. They're owned by Altria, and they own Juul as well. So how about let's change gears a little bit. How about the EVALI, the e-cigarette vaping associated lung injury? It really came out as concerns with, individuals that are using e-cigarettes and lung problems. But in reality, over time, we discovered, gee, it's not just respiratory problems, but it's also a lot of other symptoms such as fever and chills and weight loss, and then the GI symptoms, nausea and vomiting and diarrhea that are associated with e-vaping. It's kind of like, in a way, what we found with people that have cyclic vomiting syndrome that are using marijuana, hyperemesis, if you will, and that sort of thing. Marijuana is not only affecting maybe cognition and psychomotor speed and lung problems, it's now affecting the GI tract as well with some individuals that have this cyclic vomiting syndrome. So when this patient comes into the clinic, um, you know, uh, taking a history, as you know, and looking for signs on the exam, and maybe laboratory, depending on what you do and what your targets are, may be helpful. And so having a discussion, that open-ended conversation of when did you first start, what's your pattern of use, what's the longest you've gone without using, how did you do that, what are kind of triggers and general triggers, as you know, for people to have substance use disorders, or people, places, things, and emotions. People, places, things, and emotions are the biggest triggers for substance use. And then looking at their motivation for quitting, and I've given you some of that already in terms of thinking about whether it's cost, or you can use other kinds of motivators to quit as well. And then untreated psychiatric illness or mental illness is a big deal. Remember, it's one of the 4 ingredients that determines outcomes. And you can also look at other associated medical problems as a result of someone using. The next part of, you want to look on the exam, and so are there stains on their fingers or skin changes, if you will, teeth changes. And sometimes these are motivators for people because they don't like those effects of the physical appearance or the way it makes them look on the outside, or they've got a cough, or they're short of breath, or, you can look at things like blood pressure, and put the whole picture together. Sometimes you can measure CO2 if you want, and or looking at, hemoglobin goes up with this, or chest X-ray, not only for the exam and purposes of looking at where they're at within their use, but sometimes incentives to provide motivation for them to take a look at, it's time for me to try to stop. Now, when we look at how easy is it to stop, and what does the data show us, right? There, by having a discussion with the patients, we'll see that many individuals have a better chance of stopping if there is a discussion, if there is that in the history, and whether it's a screen that's done or the clinician just brings it up. But often this is overlooked. And I said this from the get-go, that the overlooked substances that are causing the most problems in our country are tobacco. And then for alcohol, interesting enough, it's not overlooked as much as it's, for many providers, it's a sensitive thing. You ask them, do they drink? And the individual will say, oh yeah, I drink, but it's just socially, that's the end of the conversation. And because often people, they know that it's stigmatized. And so they'll say socially, when in reality, the amount that they're drinking wouldn't necessarily be considered socially. And the parameters around drinking from the most recent data are changing in our country. We don't have time to go through that today, but they are changing. So don't stop at the social use, or don't stop at the, yeah, I smoke, but I don't really smoke that much, or I just kind of smoke, when I go out or whatever. Go into it a little bit deeper and figure out what they mean about, well, I'm just smoking socially, because you may be just, oh, when they're going out Friday night and having a couple of drinks or something, that's the only time they're drinking. That may not be what socially means. So don't stop short of kind of digging into it a little bit, because it does have an effect on their life and their quality of life and many other domains. And so get a little deeper into that discussion. All right. What are there's only so much time in a clinic visit. Um, and even though we are having kind of improved AI to assist with kind of clinic notes, whether it's DAX that's a part of Dragon now that will create notes. And I hope some of you have heard of that. It's really associated with reduction in clinician burnout and so on. But nevertheless, there's still limited time um, with seeing a patient. So where's the bang for the buck? And I say think of Fagerstrom, and um, this gives you an idea of kind of how addicted someone is when you look at the number of cigarettes they're using per day and the time to their first smoke, and then are they how often and frequent are their withdrawal symptoms, and you're measuring cotinine and so on. I would do this, or I would suggest you do this right here. Look at the number one here. How long does it take for that first smoke? And look at number four. Okay. Number one and number four. If you're only going to ask two questions, by far and away, the biggest bang for your buck is these two questions. How long does it take for your first smoke in the morning? And how many cigarettes are you smoking? And if you know that they're smoking with less than 5 minutes and they're smoking, you know, 20 or more, right? And especially 30 or more in a given day, the chances of them having a severe kind of tobacco use disorder are really high. Those two questions are particularly important. And I usually you don't need to go any further than that. You certainly can. Um, but if nothing else, that how long till the first smoke, and then how many are you smoking during a day? Withdrawal is an often overlooked kind of phenomena that leads to in and out. Tobacco comes in and out, and people keep, go back to wanting to use again. They want the stimulation, or they've got the cravings, or that are emerging, or they've got the withdrawal symptoms of change in mood. They're anxious, they can't focus as well, they're restless, or for some, they are like, here I go back to eating again. I don't want to be eating, and so they'll smoke again to reduce the eating. The cravings usually aren't persistent, but some of the other withdrawal symptoms can be. So just know that cravings can drive use or repeated use, but especially the withdrawal symptoms can, and that's often what people go back to smoking. Because they go into withdrawal, whether it's related to their energy or mood or um, appetite or what have you. Now, let's talk about differences in males and females here, if you will, and predictors of abstinence. Um, those individuals that can stop using easier have a lower level of dependence. That's not a surprise. And they tend to have more education and higher socioeconomic status. They tend to be older and males. Women have more difficulty, and their the number of quit times is important because you want to incentivize those quit times. So when you think about addictive potential, and I told you nicotine is very addictive. The second point I wanted to make, besides it being that goes along with it being very addictive, is that it's hard to stop using once you get to that group that's beyond the mild use. It is very difficult, and a small percent can only quit using nicotine. So it's very important to think about um, this group and targeting this group because of the addictive potential. Quit rates from willpower, if you will, are very, very low. Women in particular struggle, and they are more affected when you look at the studies by not only socioeconomic status, but by mood or negative affect. And um, varenicline is more effective. So Chantix has been, the old name for it, but varenicline tends to be more effective for women in particular compared to some of the other treatment options, such as Wellbutrin, which is Zybrand, or various nicotine products. So let's ask, how much are you using? How long till that first smoke? how many cigarettes during a given day. And because a lot of people are making attempts, but they're struggling, and less than 5% ultimately succeed on a given kind of attempt, if you will, without treatment. And so 6-month quit rates aren't very good, if you will. So build on this. And this is not a one and done conversation. When that person comes back in, a lot of people have hypertension, somewhere in the neighborhood of probably close to half the adult population, or somewhere around that, a high percentage of people. Well, if they're smokers, their blood pressure may come down. And so it may be an incentive, right, for them. So you're not just reviewing the blood pressure when they come in. You're sticking with the kind of conversation around and bringing it up over and over around how you doing with smoking, where you at, um, and getting that conversation into the mainstream of your discussion with them. But not only that, you're whittling away, if it's a harm reduction approach, at reducing the number of cigarettes that they're using. Let's talk about strategies for not only harm reduction, but smoking cessation, if you will. Many people can't go from an all or none phenomena when it comes to smoking. And so when you look at the use of e-cigarettes versus kind of nicotine replacement, e-cigarettes do pretty good. So pay particular attention to the yellow here, what's in yellow, and that is um, from large studies, and this is from 1,600 smokers. When you compare people that are using e-cigarettes to versus no cigarettes, there's not only a greater reduction in people transitioning from using to not using, but the quit rates for daily smoking for e-cigarettes versus no is, roughly 46%, and it has a large impact. If you look at the second study that was in the New England Journal on the right, at 1 year, those individuals, again, down in the yellow, that were able to quit using, within this study was 18% with e-cigarettes as a transition in harm reduction, to 10% for nicotine replacement, again, after a year. So there was some question, and here's the take-home point with this slide. There was some question as to the notion that you were hearing out in the general culture, and that is, if I transition, this will help me get off. And there was a lot of skepticism. And now we have data to say, you know what, there is some merit to going from combustibles to e-cigarettes as a transition for trying to stop smoking, just despite still there being risks. So there is that harm reduction approach. Many of the nicotine replacement therapies, patch gum, lozenges, are over the counter, and they can be used with other modalities, whether it's Wellbutrin or varenicline, or even the e-cigarettes. And so there are a number of kind of reasonable replacement strategies that are nicotine. And think about, if you're going to use a patch, where do you start with the dose? So this nicotine content in products, you get an idea of, okay, cigars have quite a bit of nicotine in them, right? And you get an idea of its with its cigarettes, or whether it's mini cigars or Juul, how much nicotine is in a given amount that you're using, and then you can start with a patch. So some people will need, a couple patches that are really potent if they're using a lot, believe it or not. So they may need 214s or something, and then gradually reducing that over time, the patch over time, depending on the nicotine content that they have. So you want to be able to make a guesstimate in terms of where to start with a patch based on the amount of nicotine that they're ingesting or taking in during a given day. And that's what this slide really tells you is, okay, here's the content, here's the thing to think about in terms of the dose or the patch. Same with, you can complement the gum or lozenges depending on how much is smoking, someone's smoking. And, with the gum, it's the chew and park method. You've heard that over and over. But, you can add the gum or the lozenge to a patch. You can add it to Wellbutrin. You can add it to the varenicline, if you will. And so just they need to make sure they're using this right. But it's another aid to help them. Then there's various other strategies that whether you're going to use the spray or the puffer, nasal spray or nicotine spray. And this is just kind of some strategies in terms of how to use this. Probably use much less than the other three modalities, whether it's the patch or the gum or the lozenge. But nevertheless, it is a possibility, and it is a kind of, in some cases, hand-to-mouth sort of thing that they're used to with maybe smoking. So it's another consideration that is out there that may be worthy of thinking about. So here's some data about it. I'm not going to read the data. It's in here. You can review it if you want. The idea is it's nicotine replacement. So varenicline works mechanistically as a partial agonist at the alpha-4 beta-2 receptor, which is where a lot of the action of nicotine has its effect when someone ingests. And so it's a activator that can be, in essence, a replacer. And it's can be used with some of the other nicotine products. It's, again, more, if you're thinking of, in general, women, it's worthy of consideration. It's not to say you can't use Zyban, which is Wellbutrin, which is mainly a norepinephrine agent, does have some dopamine reuptake effects as well. You know about this medicine in terms of it being used for depression. It's the safest in pregnancy. And contraindications are active eating disorder, that's binging and purging, if you will, and then epilepsy or seizure disorder. So it's worthy. Both of these agents can be combined with nicotine products. And there's a titration when you're using varenicline. You start Wellbutrin while someone's still smoking, and then add to it. Can we combine things is really what this slide is saying. I've just said that. Bupropion or Wellbutrin with nicotine, yes. Varenicline with nicotine replacement, yes. You can combine nicotine with nicotine. Most studies say you can probably combine the varenicline with bupropion, and there's some concern about that with interaction and side effects, but you probably can even add nicotine to that. So it's probably a safe thing to do when you're combining the latter that I've mentioned. Now let's just take a look at kind of the data when you use the Chantix or varenicline compared to bupropion and nicotine. So it's the varenicline is the single most effective agent that we have to treat substance use disorders. And so when you think about strategies, it's often a very reasonable thing. All medicines have side effects, so know that there can be some side effects with this as well, whether it's making someone feel kind of agitated or bad dreams. But there can be side effects with any of these agents, and you all are aware of that. So when we get to kind of the take-home points, and we're at the end here, really think of harm reduction initially, whether that's divvying out your cigarettes. If somebody has a pack of cigarettes and they, let's say, have a significant other in their life, and that other you give the other the responsibility to say, okay, I want you to help me here, and they say, okay, here's your pack for today, and the first week you have 20 a day, and the next week they take one cigarette out and they give the individual and say these 19 have to last you throughout the day, and each week you go down by one. When that's a harm reduction strategy. So when you get towards the end, I tell people, if you've got that one cigarette, you're down to that one. Um, take a couple drags on it, put it back in the pack and save it for later because you may want it. And gradually you're just whittling your way off of kind of cigarettes. Or if you're going to use, medication, whether it's Wellbutrin or varenicline or nicotine replacement, those are effective strategies. Don't forget to ask, how long till the first smoke and how many are you using a day? And then think about even e-cigarettes as a strategy to come off of. And so when you think about um, treatment options for substance use disorders, besides those four ingredients and besides the large predictive potential or addictive potential of nicotine, there's really only three categories of substances we have medications for. And I'm not saying medicines are the end all be all, but alcohol, nicotine, and opiates. And so this is the third category where we have the greatest likelihood of making a difference in someone's kind of life, if you will. And so think about nicotine, and treating it as a use disorder. So I'm gonna stop there. I know this isn't the most exciting topic, and it's often overlooked. I appreciate that, but it's one that we have the biggest problem. It's the problem that's the biggest in terms of substance in the state of Nebraska.
Thank you, Dr. Stoll. Before I forget, we had a couple requests for the your slide deck. Would you be able to send that over to me this morning and I can
Sure.
blast that out later this morning?
Yep.
Okay.
Yep.
We do have a case. We've got about 7 minutes. So I can read this case. We got a case in the chat from Clinton Jones. Dr. Jones has a patient, or actually a group of patients. They are 70 years and older veterans at a vet home. And he says nobody, including himself, has been assessing or treating them for tobacco use. The thinking is they have been smoking forever and won't stop, so why get into power struggles towards the end of life? How do you bring this up respectfully?
Um, if I understand right, uh, the individual is a 70-year-old fellow that has no desire to quit smoking, is the way I understand this. Um, and if and if they have no desire to quit, and you've had that discussion with them, and you feel like, I've had the discussion about, not only the risks and benefits, but what their quality of life is like, and if there's, what are the incentives for them to, can they leave the vet's home, or are they stuck there? Do they have the opportunity to go out and do some, things with family? Are there limitations that are, as a result of their smoking? Um, that may be a strategy. It may be a strategy to say, how about we try something? You keep smoking, but let's try something and see if it makes a difference, whether that's uh, adding a patch to what they're doing and see if they can, if that cuts down their kind of desire or cravings. It may be the same with Wellbutrin if there's not contraindications. And in some cases, it unfortunately, you have to just let it go. And if you feel like I've had the discussion, I've offered these, or they've tried some things, and you've gone back to them and said, you know, in essence, um, why are you so resistant to stopping? What is it about this? Um, and you've expressed your concern and so on. Sometimes that's as good as it can get, unfortunately. In other words, there, if you feel like you've done just, enough, put enough effort into it and so on in your discussions, and um, there's not something else that's going on, meaning an anxiety problem or depression problem or other issues, sometimes it just there's nothing else you can do. And so I wish, and there are clearly, I'm glad you bring this case up because clearly we've all seen these individuals, and it's my choice. I want to smoke. I like to smoke. I'm not going to give up smoking. It's the same for some of those individuals that continue to drink despite um, having um, liver problems or recurrent pancreatitis or what have you, or that are on oxygen and they take their oxygen off to smoke. And so there clearly is that group, and that's the more challenging group. But I try to get them to at least say, okay, let's, I hear you. How about we try this strategy for a month and let's see how it goes, or see if you can get them to buy into something. Short of that, I don't know that there's any other, and others may have, and I'm interested in others that are on the call here. If you've had success with this type of individual that's really doesn't want to quit.
Any comments, response to Dr. Stoll's prompting there about getting individuals to quit nicotine? You can feel free to speak up, or you can type your responses in the chat here. We've got a few minutes left today, this morning.
The other leverage sometimes I use, and it goes back to something you've heard me say, and I hate to sound like a broken record. Um, Substance use disorders, in my opinion, are family problems, as is as is things like child developing kind of diabetes or mental illness often is a family problem. So if they have a connection with somebody that's important to them, that individual may have influence in their life, and so that may be a strategy to think about.
Just one quick thought for you. I don't know if this is helpful or not, but the conversation around smoking and nicotine is always a little bit awkward in the individual that does not want to stop smoking, you know? And so just towards the end of your question is like, how do you bring this up prospectively? Like a lot of times I just blame it on the things I have to ask patients. Like, hey, I'm supposed to ask you this. Like, is there any interest in stopping smoking? Right. And so again, it's a little bit of like just pushing it off on the system, but that way at least I can ask the conversation without them feeling like threatened by me saying like, tell me about your smoking and why you're not stopping and all of this. It's just like at least I'm starting to have that conversation, as Dr. Stoll said in his presentation there, like as long as you're having that conversation, like there's hope that there might be a change, right? But if they're 7 years old, they may not want to change at all. And so that's the reality of where they might be at. But just one, thought for you on that.
Thanks, Ed. I'm not seeing any other comments, so I think we can call it the end of our training here. I dropped a link to the evaluation survey in the chat. You can grab that there. An email will also be coming out maybe in about an hour or so this morning. So thanks to Todd and the rest of the Echo team, and thanks for joining us this morning.
Have a good weekend, everybody. Take care.
Thanks, Todd.